when the recording starts. That's fine. So I think it started recording. So welcome everyone. My name's Rebecca Fawcett and I work in the safeguarding team at SWIFT, so South West Yorkshire Partnership Foundation Trust. And we put on this session, so we're going to be talking through sort of the additional vulnerabilities when it comes to mental health and safeguarding. And then I've got Aldwyn from SPA to hand over to talk through kind of the role of SPA. Do you just want to introduce yourself, Aldwyn? Thank you. You're on mute.
Hi everyone, my name is Aldwyn. I'm team manager for Single Point of Access team in Barnsley. Sorry for joining a bit late. Technical difficulties, as we'd say.
Thank you very much. So I'll just bring my slides up. I'm not sure it will take quite an hour. It definitely won't take more than an hour, but I think it probably will take a little bit less than an hour. But we'll have plenty of time for questions and things at the end, or just pop hands up as we're going through. So obviously we've just tried to pull this session into Safeguarding Week, but it had been identified from a challenge event run by the Safeguarding Adults Board that there was a lack of really understanding about what single point of access is and how to refer and everything like that. So we put this session together. Hopefully by the end of the session, we'll all have a little bit more understanding of why people experiencing mental illness might be more at risk of abuse or neglect. We'll refresh knowledge on professional safeguarding duties when someone is experiencing at risk of abuse or neglect, and then I'm going to hand over to Aldwyn at the midpoint to talk through the role of SPA, single point of access, understand how referrals into SPA are made, gain a bit of an insight in the process when a referral is received into SPA, and focus a little bit on consent from service users when making referrals into SPA as well. So just as a bit of a refresher, the Care Act identifies 10 types of abuse, which are listed there. So we've got physical abuse, domestic abuse, sexual abuse, psychological or emotional abuse, financial or material abuse, modern slavery, discriminatory abuse, organisational or institutional abuse, and neglect or acts of omission, and obviously self-neglect as well. And in the context of legislation, specific safeguarding adult duties apply to adults who have needs for care and support, are experiencing or at risk of abuse or neglect, and as a result of those care and support needs, they're unable to protect themselves from either the risk of or the experience of abuse or neglect. So just to unpick those points a little bit, so needs for care and support might be the help that some adults need to live as well as they can with an illness or disability that they might have. So it can include help with things like getting out of bed, cooking, eating, washing, being part of the community. It might be emotional support at a time of difficulty and stress. And obviously it includes the care and support that's given by sort of informal means, so through family and friends, as well as through sort of, formal measures like care agencies, and it also includes when care and support needs are not being met. The adult is experiencing or at risk of abuse or neglect, so we're probably not going to be thinking about safeguarding if this criteria doesn't apply. But just really important to highlight that obviously when we feel that someone's at risk of abuse or neglect, we don't want to wait for that harm to happen before we take action. We want to be taking the preventative action. And as a result of the care and support needs, the adult's not able to protect themselves from either the risk of or the experience of abuse or neglect. That third criteria can be a little bit trickier sometimes to unpick, particularly if you're an agency that might have quite limited sort of support or intervention with an adult. It's not always clear cut whether somebody is able to protect themselves. But if we do feel that an adult meets this 3-stage criteria, we would be looking at sort of safeguarding adults referrals, and this is what social care will look at when deciding whether to undertake safeguarding inquiries, so often referred to or known as Section 42 inquiries. The purpose of those inquiries is to look at whether abuse or neglect has occurred and if any measures need to be put in place to protect that adult.
would it be possible to ask a question? Just a quick question then, please.
Please do, Sally.
I'll put my camera back on and then you can see me. I've just gone through assessing a lady who was coming into our service potentially for counselling. She's in an abusive relationship, which she's not acknowledging as abuse. She's cut off from all her friends and family. And we're not sure if we can offer her support, but she does need some support because we don't feel that we can collude with the fact that she's in this abusive relationship. Would that be somebody that we could refer to you for assessment?
So I don't work in social care, but you could, I suppose, does this lady, I think it's a good example because it highlights what I should have mentioned in that. So if somebody doesn't meet this 3-stage criteria, we don't just do nothing. We might think about sort of support from the police or support through other avenues like multi-agency risk assessment conference, MARAC, or sort of support from other.
She has had one of those actually. So there's a protection order on the baby who's now with her mum, and she has stayed with this gentleman who she's with. So there has been a multi-agency meeting. So she's got a social worker. She's been supported by IDAS. But I think in terms of mental health, we're just not sure what we can do for her. She's not got a clear goal around sort of symptoms, but she does need support.
But does she need that care and support, or is she managing to live independently, or does she need that?
She is. Support? Yeah, she is. Yeah, she's living independently. Yeah, definitely.
Yeah, I think it sounds like it doesn't meet the criteria for sort of a safeguard inquiry, but I'll drop you an email. You work within my trust, don't you, Sally? I think in Swift.
I'm a counsellor in talking therapies, Barnsley Talking Therapies.
I'll drop you an email after and we can have a further discussion about it.
Oh, that'd be great. Thank you. Sorry to interrupt.
No, it's good to have somebody talking rather than just talking at people. So
thank you.
So in terms of how those safeguarding adults' duties apply to people with a mental health need, obviously not all people who experience mental health problems will be classed as an adult at risk or an adult with care and support needs, because some of them won't receive care or support for their mental health problem, or they receive care and support for the mental health problem but are experiencing or at risk of abuse or neglect. There are people who experience mental health problems who have care and support needs and experience abuse or neglect and are unable to protect themselves, which would be classed as an adult at risk. And all organisations obviously have a duty to care for the welfare and well-being of adults with care and support needs and to safeguard them from abuse or neglect. We know that people living with a mental health condition might be more vulnerable to abuse or neglect, and there can be multiple reasons for that. So it might be that the condition might be seen first and the person second. That can result in the person not being listened to, understood, believed, or taken seriously, and being on the receiving end of negative attitudes. The condition itself may impact on people's ability to understand personal boundaries, judge the motives of others, have the confidence to speak out or physically defend themselves. The person may be unaware of who to talk to. They may have fear of intimidation or getting people into trouble. They may be scared that they will lose services, and they may be unaware that they are experiencing abuse or neglect. Involvement with lots of different agencies might mean poor communication between agencies, and safeguarding issues might be missed. So really important that we don't just assume that other agencies know what we know. And there may be an increased risk of an organisational abuse if the adult is admitted to sort of inpatient settings. There is some research around mental health and domestic abuse specifically. So Safe Lives found a strong association between having a mental health problem and being a victim of domestic abuse. And mental ill health is also a risk factor for being a perpetrator of domestic abuse. People with mental health needs were more likely to have experienced each type of abuse, particularly sexual abuse. And of the individuals who had attempted to leave the perpetrator, those with mental health needs had often attempted to leave more times on average compared to those without mental health needs. Mental health problems are also a common consequence of experiencing domestic abuse, both for adults and children. I've popped the report into this slide, and if you do want a copy of these slides, I can get those sent out if people pop their emails in the chat box at the end. So I'm going to hand over to Aldwyn at this point to talk a little bit about the role of SPA, and just let me know, Aldwyn, if you want, when you're ready for me to flick through the slides.
Yeah, thank you. So SPA on a whole, I know most of you might have heard SPA, terminology, abbreviation. It stands for Single Point of Access Team. There are a few dotted all over the country. We've got one in Barnsley. There is one in Wakefield and other parts. So in terms of the role of SPA, we're an assessing service. And when we say assessing, it's mental health assessment. So we assess folks, who struggle with the mental health. Some of these folks, they are brand new to services. Some we might have known them already from previous engagement, but it's about that presentation at that time. So even if somebody's come through last time, it were anxiety, this time it might be depression, and it's linked to something, whatever it is, when they come through, that's our role. We used to have it used to be that where we had every referral coming through to SPA. More recently, we've sort of tried to see if we can signpost or make sure referrals are appropriate. So we more or less a gatekeeping assessing service for secondary care mental health services. So we've got sort of primary care, and now we've got the introduction of the primary care nursing team in Barnsley, and that's predominant. It's a new service that's set up now. Talking therapies do sit with primary care in terms of their level, and then you've got the secondary care services, which is your community teams, which is your core team, your enhanced teams, IHBTT, which is the intensive home-based treatment team. So, and then your older adults for older people's mental health services. So we tend to do assessments, and we tend to see if it's a case of, in terms of gatekeeping for secondary care. That's where we've shifted to now. When we look at carrying out the assessments, we've got a time frame which we aim to stick to, and it's usually within 14 days for routine. Anything that seems sooner, we try and engage people within 48 hours. It's not a crisis service, but it don't mean that we can't deal with urgent referrals. So we might get referrals coming through, and some might seem more urgent than others. What I would say is if it's something that's needing a crisis response, that's very much different. However, we are happy to have those discussions, for anybody that's needing to make a referral. Now, when we look at our role, in terms of assessments, that can look like two different things. So we're looking at, we carry out a full assessment, or it could be in the form of a mental health triage assessment. So an initial triage assessment, it's basically on receipt of a referral, we'll make some contact with the client, and it's that first step into our interaction. So, we've got a referral, it's come through, we identify whether or not it might be suited for a different service. So it could be that it might be suited for, say, Sally's team, then talking therapies, or it might be suited to the primary care mental health team. And we would signpost there or forward on these referrals if we need to. But there are others that we might select, and we might think these are beneficial in terms of having a mental health triage. So when we do that initial triage, it's basically contacting client to say, look, we have received a referral, we've screened it, we are aware of what's been happening, and then it's that first step in terms of tell me how things are, what's happening more recently, and then we can build on that there. And then the aim of it after having that triage is basically, if it is seen that the person or the patient can benefit from those wider services, which is third sector services, we would more or less try and see if we can signpost at that point, rather than people are being referred into services unnecessarily and not meeting the criteria to then be discharged. And it's about that sort of onward referral, and then the chances of rejection if they're not meeting that criteria. So if the need can be best met in other services, that's what we would aim to do. There are a few factors that are considered in terms of when we have those interactions. So yes, we'll look at the presenting problem, we'll look at what support they've got in place at the moment, we'll look at things like risks, in terms of how likely is it to escalate, and we look at things like family support, any drug use, that sort of thing. And one of the things that we do, which it might be on one of the slides further on, we do consent is very important. Yeah, you can flick through, Rebecca, thank you. So in terms of referrals into SPA, majority of the referrals that we have, it does come from the GP. So if we have 100%, I'd say probably 70%, 60% comes from the GP. There are other services, partnership services, that we accept referrals from, and there are also external services. So just a few from the list, it could be consultants, health visitors, midwives, hospital staff, local authority, social workers, police, other parts at trust, other parts at NHS, youth offending teams, schools as well, bearing in mind that would more sit along the lines of college, because we are an adult service, so we wouldn't a referral for kids wouldn't be appropriate. CAMs of their own SPA within their children's services, but we do accept referrals from family support workers. We've got social prescribing, IDAS, Mind, veteran service, some charity organizations as well. But that's just to name a few in terms of who we accept referrals from. Where possible, we would always encourage for folks to engage with the GP. Usually more often than normal, the GPs are very much of that, where they would have had some history previously. And also they are also able to initiate first line treatment. So when we look at what somebody is experiencing with regard to the mental health, it could be that the GP after a consultation might see it fit to prescribe maybe some medication for sleep, anxiety, and antidepressant, something like that, So where possible, if they can engage with the GP first instance, who've got that basic knowledge of what the health history is like, we would always encourage that anyways, you know. Then, yeah, looking on, as I've mentioned before about the consent, it's very important that we get consent from clients. We cannot act on any referral unless it's something where they are deemed not to have capacity. So as long as the person's got capacity, they can make those decisions. They know what's right for them, whether it's right or wrong. It's not something that we can go against. So anybody that's referring in, we would ask that question: have we got consent? Are they agreeable, you know, for you to make that referral or for that referral to be made? If it's a case where we do speak to them and they says, look, I didn't know about it. No, I don't want to be referred into services. It's my choice. That's where that stops, you know. We don't accept self-referrals. It's very much important while we say it. It definitely is one where GP or some professional refers in, so we're not a self-referral services. Now, in terms of things to be mindful of, so when we're looking at things like risk, you know, it's very important because some of the service users that we come in contact with, whether it's via referral, assessments, engagements, whatever it is, sometimes they might have a colourful history in terms of forensic, that sort of thing. And it's something to be mindful of when we get referrals. You know, we will ask those questions, but we do expect that that's something that would be communicated to us in terms of you know, somebody's assaulted somebody, or, you know, we've got a duty of care to protect, you know, our staff as well as other patients, you know, bearing in mind we've got a busy reception area and, you know, we don't want to put anybody at risk, you know, that sort of thing. So if anybody's sort of from that colourful background in terms of risk, then that's something that we do take in consideration. Yeah, so assessments that we offer tend to be face-to-face. You know, usually it's in a clinic setting. We are based at Lumwood, just below Priory campus at the corner of Littleworth Lane. So anybody that's had the COVID jab at Priory, we're just down the road from there, in case it drags any memories. And that's where we tend to operate from mainly. So we do clinics all over. One of our clinics, we have one at Kendry, which is at the James Barnes Centre. We've got one in Penistone. We've got one in Hoyland. We've got one at Thurnscoe. We've got one at Grimethorpe. We've got one at Cudworth. We've got one at Roundhouse. And where else? Yeah, I think that's it in terms of Womwell. Yeah, did I say Womwell? Yeah, I think so. Yeah, yeah, we've got Womwell as well. So it's about trying to bring the clinic to those in the community. Not everybody can get to Lumwood, and you know, everybody's facing issues around finances, and some will often say, well, I don't get paid, so if it's close to them, then you know, it's easily accessible. So we do clinics face to face. There are times where we will offer telephone appointments, and that's quite useful. You know, if somebody's not able to attend, and there are sometimes folks that might struggle with things like agoraphobia, who've not left their house in a while, that sort of thing. So they might benefit from that. And it's again another way that we found post-COVID that were quite useful after we've, you know, gone to doing like loads of telephone assessments. As much as we found it always beneficial to have face-to-face, we kept that aspect of telephone because a lot of people do find it quite helpful. So we do home visits. Usually home visits are very much reserved for the elderly, people who are in care homes or who have like a disability that can't really get to a clinic setting. We try and see if it's something that we can engage, you know, folks again as our way of trying to engage with the community. But I know other teams, they'll do home visits like as part of the regular daily operation. We've got set clinics that we tend to do. And like I said, these are for extreme cases or people who are elderly or have got that disability. Yeah. And usually when we do assessments, sometimes it can be with two practitioners. When we say practitioners, we've got a diverse team of practitioners, so they're not all nurses. They are sometimes, it could be a social worker, it could be an OT, but we all have the skills to do an assessment with regards to somebody's mental health. So it could be varied professions. Sometimes it's one member of staff, but if it's possible, we will try and have two. Yeah. An hour slot is allocated for this. So when we say an hour, if it could finish before, but what we don't like is to provide a rushed experience. So if it finishes before, it's because you've said enough or we've gathered all that we needed to, and there's no real reason to go any further. But there are times when it gets to an hour and we think, all right, we haven't got through it all today. We need to see somebody again, and there is scope to do an extended assessment if needs be. So that's another thing again. Now, when we do an assessment, we do linking, with the GP, in terms of feedback information. So we send a letter to the GP, and basically that letter is just to say, look, they've had an assessment today. This is the outcome of the assessment. And it just goes to show that if there's anything that service user might need to access in terms of their records or follow up on or know the outcome, then the GP's got some record of that on their system as well. We ask each person to sign what we call an agreed plan. An agreed plan is basically just a short document just to say, look, you've had your assessment today. This is the outcome. It could be access this service, do this, do that, or we'll refer on to that service, that whatever, or it could be an extended assessment is arranged for you at this. So whatever the outcome is, we document it and we ask them to sign that copy. And in signing that copy, they keep a copy and we keep one and scan it onto their records. It just shows proof that they have agreed to what the outcome is, just stops them going away or coming back saying, well, that weren't the outcome. So just a bit of a backup as well. All right. So overall, in terms of SPA, I know some folks might have heard of it before. They are very much, it's a service that's always developing, and more so recently tying in with the CMHT, a change in model, but very much still the core of it is assessment. So, if it comes across in terms of what we do, it's assessment, signposting, triaging, gatekeeping assessments. Overall, it's that point of entry, but more so gatekeeping for secondary care mental health services. Yeah. Any questions? Anything not anybody not clear on?
Thank you. I'll just stop sharing so I can see people and stuff. That's taken much less time than perhaps we anticipated, but time for any questions if there are any.
In terms of referrals, are the referrals made over the phone, or is there a certain form that you have to complete online?
Yeah, we haven't got an online form,
Right.
but the GPs very much have got a copy. Some services have got a copy of it. The ones that we are usually accepting more referrals from, they would have a copy, but we do welcome referrals by phone as well. So nothing's wrong with phoning up and saying, look, I'd like to make a referral for somebody that I'm working with, Are you from, Katie, are you from Barnsley?
I'm from Barnsley Homes.
Is it from Emily's team?
Emily Ellsworth.
Yeah.
Yeah.
Yeah, we do accept referrals from Emily as well. So yeah.
Brilliant.
Any other questions? It's been a bit of a whistle-stop tour, but hopefully it's been useful.
I was just wondering about those forms and if we could use them, if I could get hold of some of them from the doctors, is that acceptable, you know, do you email them to you? I'm from adult skills in the council, so we're working with 19-year-old and up, and the majority of, I'm the pastoral mentor, and the majority of issues are mental health related.
Are you aligned with the GPs?
No, we're adult skills, so we're there's college, and then there's adult skills in Barnsley, along with, you know, recovery college, but we're adult skills.
Right, okay. I mean, if you drop me an email, we can have a look into it.
That'd be great.
I'll put my email in chat, and then that'll we can have a further catch up with regards to
That's
that one.
great.
Yeah.
Thank you.
Yeah.
Much appreciated.
Sorry, can I just ask another question as well? I'm always confused with the difference between single point of access and then is it IAPT?
Yeah.
I get confused with these two and who to refer into, you know, which one would be best suited, if, you know, to refer into if required.
Yeah. So IAPT, it's got a change of name now. So what you might know as the improving access to psychological therapies, they're now called Barnsley Talking Therapies, so BTT. And they are the difference is they are a self-referral service, but when you think therapy. Interventions around like anxiety management, depression, low-level PTSD, you know, low-level trauma work, single trauma, things around sleep hygiene, that sort of thing. It sits very much within the primary care lower level type thing. So if it's first time presentation and that person has some level of functioning, they are able to cope, but there is something at a lower level, especially a first time presentation, then they can self-refer to that service, you know. Obviously, if it's above primary care setting, then that's a different thing. That's where probably you'd be thinking, is it for secondary care, which we are able to do that initial assessment. Within the Barnsley Talking Therapist service as well, they will do screening assessments, so it's more or less to see if it's appropriate for their service. And I mean, if it isn't, they can always step it up if they need to. So that's the difference, you know. One's more or less self-referral along the lines of therapy, and then our service is more or less, yes, assessments, but thinking more along the lines of secondary care, but very much not a self-referral service.
Lovely.
I think the name change makes it easier to understand. I think talking therapies is a little bit more self-explanatory than IAPT, certainly for me anyway.
Definitely.
But it's the different sort of levels, isn't it? Sort of any mild anxiety, depression generally would fit under sort of talking therapies, and more complex, enduring mental health is probably more suited to secondary.
They can do like your CBT, lower level, online CBT stuff as well, you know. That when you think that service along with primary care, you're thinking lower level, you know. When you think secondary care, you're thinking severity. So, you know, something like psychosis or extreme agoraphobia or multiple traumas where somebody's had repeated psychological trauma, and, you know, you're thinking along the lines of hearing voices or, you know, self-harm or attempted suicide, you know, them type of things, you're thinking more secondary care. But anything like your anxiety, I've started some meds, but I could do with learning how to manage my anxiety. You're thinking like either primary care, recovery college, talking therapies, that sort of thing, you know? And it's also mindful as well to be aware that sometimes as well, when we look at therapy, we might think, oh yeah, they do therapies, talking therapies, but they are specialist services as well. So something like sexual abuse, we wouldn't knock somewhere like BSACs, Barnsley Sexual Abuse Rape Crisis Service, because they're specialists, you know. I always like Nick to go into your GP, and your GP is like a one-stop shop for everything. But when you go to your GP, if you need dermatology, they'll have to do a referral into dermatology, you know. It's the same way with talking therapies, BTT, you know, they can offer that overall therapy, but if it's something that's specific to a certain service, then you're better off trialing the specialist service. So like bereavement is a specialist one. Barnsley Sexual Abuse and Rape Crisis Service, that's one as well. You know, I know IDAS don't do counselling as well, but it's a specialist service, you know. Amparo for people who experience loss by suicide, you know. So, you know, various different things, and that's why we welcome discussions as well in terms of referrals, because it might be that somebody's thinking of referring somebody in, but they're not sure of what's out there. And we are very much tuned into various services that can help folks, you know, like to help promote that awareness, you know.
And sometimes it's not one or the other, is it? It might be that somebody's in an abusive relationship, so they need that practical support from IDAS, but there is a mental health need there as well.
Yeah, and it could be that things are that overwhelming that, you know, you'll say to somebody, right, so you've got all this here, you know, and it's a case of it's too much to tackle everything. And it's right, you work on one thing at a time, what's most important, and narrowing it down to one thing, you know, rather than try to, as I would say, open a can of worms. You know, it can be challenging and overwhelming for some of the people that we see, you know, and we very much wouldn't recommend two therapists working together at the same time. So it's all about doing things in a timely manner, even though we consider that it can be very much challenging, you know.
Any other questions? I think people never mind too much about having a bit of time back, so hopefully it's been useful. Thank you so much, Aldwyn, for delivering it with me, but you really led on it. I just stopped the recording.